Good morning and welcome to our monthly webcast. This is session number 111 and I am your moderator Samir Mehta. I want to initially thank so many of you who have asked us further questions about how to manage the rotablator entrapment, and during this session today I will continue to engage Dr. Kinney and Dr. Sharma into answering some of those. It was also a personally gratifying meeting for me to meet with numerous interventional cardiologists and fellows from the Philippines whom I met at the AICT meeting last week. They informed me how they have created a group which faithfully watches our broadcast at 8 in the evening, and I wanted to encourage them as I had told them. There is the site to ask questions, please proceed. The second gentleman I want to recognize is from Serbia, Dr. Sinisa Zivkovic. I hope I have your name pronounced correctly. Thank you so much for your kind words and I hope you will continue to benefit from our transmission. With these words, let me take you to the cardiovascular laboratory where Samin, you have somebody else joining us also, Roxana.
Yes, of course. Good morning to our CCC live viewers, and thank you Samir, and clearly time to time we have additional person in our during the procedure and take the opinion and work through it, and today I am very glad to have Dr. Roxana Maran, my colleague and director of our cardiovascular, particularly cath. She has created a big enterprise of the research and of course the publications which you hear periodically from time to time, or maybe like many times every day coming from her group. So I really invited her today because one of the topic today would be about the aspirin. So as you see, that aspirin really got a lot of issues or kind of in the news in last 1 month. So and her being the major person of the trial, which is a twilight. We are trying to cut down the aspirin, and we will go through those points very shortly in our didactic discussion. So I am sorry that we are a little late to start. It just happened logistically, but we are all ready to do this complex case, which we go through our slides wise. Just if we can show the slides. The disclosure, this is a 65-year-old male who came actually a few months ago with small non-STEMI. He does have in 2008 two vessel disease of the LAD and RCA. Both were intervened very calcific vessels with multiple stents and all were Zymes. Total 5 stents. He did good actually for last 9 years until have little angina preceded this small non-QMI. So EF was still normal, and that time RCA felt to be the culprit, being a subtotal and little thrombotic, but also calcified, had an intervention. And now patient is here for a 2 vessel intervention, and question always was in the referring cardiologist mind, although you will see the disease wise significant, but they still wanted to do a stress test in between. The patient has a stress test, we showed significant ischemia of the residual 2 vessels, and that is why the patient is here after good medical therapy. So Anu, you want to show the angio?
So EDP was normal, and then this same injection with the JR catheter, normal EF, and this is a right coronary artery. If you see the proximal and mid RCA stent looks patent, and this is where we are with the left system. Significant.
Actually, if you go back to show on the left side, see the calcific vessels right on the top, both mid LAD and proximal circ. So left system very calcified.
More in the circ, but yeah, both of them, absolutely.
Yeah. So you can see, I would say heavy calcium, tram track calcium in the circumflex, right, with the ostial about 50% disease, but proximal still about 90-95% lesion, and then probably moderate ISR of the ostial LAD stent, and this is where we are. Diagonal looks okay. There is a stent in the apical LAD, but just proximal to that there is some moderate 30-50% disease.
You would of course leave that alone, no?
That we will leave it alone.
Yeah.
But even the question will be the proximal
right, exactly.
LAD. So if you see stress test ischemia was all infralateral.
Yeah,
but then there is
but little bit apical ischemia, mild but severe there.
So
Yeah,
there is a spire stent in the LAD.
LAD,
It looks like I hardly see a left main. It's a very, very short left main. Almost like the stent in the LAD comes very, very proximally, and it looks like there's some ISR there for sure. You see some tissue proliferation. So I would be very interested to see what kind of technique, and is that circumflex jailed at all by the stent in the LAD? I don't know. I can't really tell, but the left main is very, very short. So I don't know, it will be, so that's why I think imaging is going to be very interesting.
Yeah, I think that's a good point. And not only that, now we are talking about just around 9+ years. So is it an intimal hyperplasia or it's a neo-atherosclerosis?
Yeah, no, it's
and it
really
was a Zions stent. It was not the first generation. It was the Zions, regular Zions, which just came in 2008.
10-year follow-up of multi-vessel 5-stent Zions in this patient.
Yes. Yes. And the culprit was actually even the RCA which came last time. It was a little proximal to the stent. So, and then of course there was moderate intimal hyperplasia, just like which we have here. Not moderate, actually RCA was a little more than moderate, and that required 2 stent with after rotablation, and now we did a Promus Premier. So with that note, we thought that we'll image the LAD. Is that the plan? Anu, what do you want to say? So how do you want to strategize now? And then definitely put a 2 stent approach for this complex lesion, which is a 011 by definition. Yeah.
So I think what we'll do is we'll image the LAD first, and circ we know for sure has significant disease, and then we plan the strategy. For the circ, since it's calcified, we will do rotational atherectomy. LAD based on the imaging will decide, and also since it's an old stent, it will be very interesting to know what truly is causing this ISR, intimal hyperplasia, or is there any neo-atherosclerosis?
But how would you differentiate? What test can you do to differentiate neo-atherosclerosis compared to intimal hyperplasia? Because by looking at it, I would say, well, it's a delayed moderate restenosis of the DES.
So IVUS, like we know, can tell us definitely intimal hyperplasia plus minus lipid, but I think if you want to do it with one particular imaging tool to tell us whether there is lipid versus intimal hyperplasia at this stage, would be OCT.
Yeah, no question.
And what would you find in the OCT? Lipid?
Yeah, we'll see the lipid.
So once you see lipid, it tells you that it's a neo-atherosclerosis.
Yes.
But what is the treatment any different?
Treatment is no different.
Treatment is the same, right?
Treatment would be the same, but also interesting would be to know whether if it is just intimal hyperplasia lipid, we may just do cutting balloon and take care of the stent, versus if we see some calcium, which we don't see right now because it's
nodules inside the.
Then we may consider use the same burr in the LAD also.
And restenting. And you restent, definitely. If you have neo-atherosclerosis, you want to restent it. So that's a new process.
What we will do right now is that we will do the OCT of the LAD, and then we'll decide, do we need rota or no. If there is no rota, then what we can do, we will do the rota of the circ. If you need rota, maybe we do rota of the LAD, and then take the same wire out and then do the rota of the circ, because once you done rota, you do not want to, later on take out the wire to do rota of the LAD.
Okay.
So that's a good plan.
Completely acceptable plan. Samin, you want to start tackling your issues, and we can benefit from Dr. Mehran to be there too.
And we'll come back to that, yes. So therefore, if you go back to the slides.
So we'll do OCT or we have to show live?
Yeah, OCT. Once you are ready, we'll go live. Once you are ready, yeah. So right now we can show the, go back to slides, and this which I have mentioned already, and this is where we are here now. Syntax was 25 at that time, and of course with the RCA intervention became 18. And this is what we are planning to do. All the complex cases, we go with the calculation of both STS as well as syntax score. In this particular case which was done, and STS was very low, 1.2. And in terms of appropriateness, now it's a 2-vessel disease, because we have taken care of the non-STEMI vessel, and it's still appropriate on double medical therapy and 2-vessel disease including proximal LAD. So 2 issues while we are trying to get ready with the OCT is some key trials from European Society of Cardiology, which is the basket small, 2 matrix 1-year follow-up, future 2 trial, 2-year data, future 2-year data, and CULPRIT-SHOCK 1 year. And then more importantly, I really want to put some more time into the randomized trials of the aspirin use as well as its duration. And lot has come into the limelight, even yesterday publication of the in NEJM, and many numerous patients are calling that what we are doing for these, what they should do with the aspirin. So basically, the few trials which we have selected, one of them is the drug-coated balloon for small coronary artery disease, basket small 2, small vessels. We have various options. There is a various definitions of small vessels, could be 2.5, 2.75, 3.0. So in this study, for the basket, they counted vessel less than 3 as a small vessel. Of the various, as you can see, the biobserver vascular scaffold actually got the bad name because of the small vessel having a higher event rate. And of course, we also know that DES has a higher event rate in these patients. There are some data of the drug-coated balloon in a small vessel, but really get to the randomized with the new generation DES, that is the all basket small 2 trial. And basically, you can see here the patients after balloon angioplasty, they did not have any dissection, and so met the criteria, then randomized to drug-coated balloon or drug-eluting stent, and those who had dissection were in the registry. And of course, what happened is some 25% of cases in the beginning had a Texas, and after that were all everolimus eluting stent. So what was the data basically? Overall, in terms of the device use and size were comparable, but the cardiac death, non-fatal MI, and target vessel revascularization is surprisingly, knowing that some studies in the past have favored DES, in these small vessel, dedicated small vessel, as you can see, there was basically no difference in primary endpoint. You might even say that if there is no prior difference in primary endpoint, although they did not report the stent thrombosis data, there was no stent thrombosis in the group. Because
well, they didn't show the stent thrombosis rates were pretty small, but I think you see that the cardiac death is in the wrong direction in the drug-coated balloon arm. So I think that was important. Small study. I think there's a lot of issues with the study, but at the end of the day, I think we need to get drug-coated balloons here in this country, and we don't have them. And I think having this study there is going to help us.
Yep. So therefore, drug-coated balloon was non-inferior to DS in a small vessel. Then they showed the matrix data. Matrix has been presented in Lancet for 30 days, and now they showed the 1-year data of both the access strategy as well as the anticoagulation strategy. And you saw that the 1 month data presented originally in European Society of Cardiology and followed by Lancet in 2015, and then now the 1-year follow-up in all the 3 groups. One, the access point of view, then anticoagulation point of view, and anticoagulation whether you continued infusion of bivalvulotin or so. So basically, the most important being the access, femoral versus radial. As you can see here, NACE, which is the net adverse cardiac event, which is the both ischemic as well as vascular, the bleeding component, the overall in favor of radial intervention, which we always knew. And more importantly, actually the difference was basically in the first 1 month, and after that was identical. And then if you see the individual endpoints are here, there actually was lower cardiovascular death, 2.1 versus 3, just about 1% lower, and more importantly, no difference in other bleeding, the other endpoint of the stroke and so, and lower bleeding rate. So key is the radial came superior in all the aspect of the lower death rate, lower bleeding, but no difference in stroke, because stroke has been some signal in the past, higher stroke rate with the radial, wait 1 second, higher radial intervention, and but at least this large randomized trial of 10,000 kind of patients really put that to the rescue, and so to the rest. Now, if you take the antithrombotic program, basically was no difference in NACE, individual endpoints somehow still remain lower mortality, and we can't explain, and of course the lower bleeding rate with that. And now question was long-term infusion, short, low dose, high dose. It basically turns out to be once you are giving infusion, overall strategy was not different, but if you give a high dose of 1.75 post PCI was little better in terms of lower ischemic endpoint. Okay, Anu. Yeah, they're ready with the OCT. Now we go back.
I took the catheter out again.
Yeah.
Okay, we'll ready. You can show the OCT now, right? Okay, you see it well?
See the image.
Ah,
Excellent.
no?
Yeah.
What's happening? Yeah. Yes?
Yes, yes.
Okay,
we
good.
see it.
Okay, I'm going to do everything together.
Looks like a single layer of stent, that's for sure.
Yeah.
That we knew because we have the angiogram done here at Sinai.
Yeah.
So now let's do the co-registration. See, that's one good thing about this is that we will have co-registration. I think they're going to come up with IVUS catheter also with co-registration.
Yeah,
Not these
that's
people.
true. Yes.
The next level, Boston Scientific, right? Let's do the co-registration. Yes. Okay.
The
Now come to the
co-registration is
proximal.
so important.
Yeah, very, very.
Really, really helps you because you see it. You're used to seeing something.
Okay. So that's a
angiographically.
diag right in the side, right
Yeah.
there. Yeah. Show
Yeah.
the diag. That's a diagonal coming in, and then you're coming back proximally. You can see there. This is right exactly.
Is there
you see the
fat
white
there?
point?
Is there some lipid pool there? You
No,
see those?
It's all
I think
intimal
it looks like-
hyperplasia.
Looks like
Come
lipid.
on.
No, there's a little bit of a lipid pool. No.
Come
I
back.
don't know.
Come back.
I saw it more. 1 second.
This is where the stent looks good.
Yeah.
You see there?
Yeah.
No intimal hyperplasia. Everybody is clear there. You see the small white line in the LAD coming towards the osteal LAD. Looking good, looking good, looking good. Keep coming back. Keep coming back, keep coming back.
Now it
Okay,
starts
now
seeing
we start
intimal
intimal
hyperplasia.
hyperplasia. Yes. So you need to see lipid within the intimal hyperplasia,
Yeah, you see those
which we don't.
lucent at like 9 o'clock? Look.
2 layers. Okay, come back. Proximal. Show
that
us the
may
2
be the
layers.
overlap.
There. Look at that. There.
Overlap.
Yeah,
Oh.
that
What's
may be
there
the
at
overlap.
12 o'clock?
No, I don't know. That one you're talking 2 stents, but it could be right
No,
that
but that's
if
just
there are
the
2
overlap.
layers. Yeah. Okay, right here, right. Stop, stop, stop. Calcium. That's
Yeah.
calcium there. Show that calcium. Yeah, that's calcium.
Yeah, you see
I
that?
don't
There's a
know. Is that
calcific
lipid
nodule
at
there.
1 o'clock position?
Yeah, that's what I
Lipid
don't
at
know.
1 o'clock position? Don't
Yeah.
go back anymore. That's a circ. Okay, here, right here, right here, right here. That's a calcium.
Even at
Yeah.
11 o'clock, what are those lucent pieces there?
Yeah. That,
Yeah.
that will be lipid behind the stent though, even if it is
Yeah.
old plaque.
That's true.
So I think we can clearly say it is a calcific, right? Yeah. Yeah.
Calcification enough to be using the rotablator?
Probably
or-
not. I think we could
I know.
do
I
it
think
with
you
a
can do
cutting
with a
balloon.
cutting balloon.
Excellent.
Yeah. That would make it
Fibrocalcific
like-
lesion, we don't see a lot of lipids, so essentially it is all intimal hyperplasia.
So based on what you have observed, what is your strategy now for the LED? A cutting balloon?
The
or-
lumen, how is the lumen now?
Okay,
Let's
here,
try
give
to
us a
get the lumen.
cross-sectional area of the lumen, right at the ostium. Ah, yes.
I mean, angiographically definitely looks quite tight at the ostium. So just go to the ostium only. Let's see the lumen cross-sectional area. Keep going further. Yeah. More,
No, not there. Come back to the ostium.
more left. Keep going.
So, I mean, a very clear expected
Yeah, right
question,
here, right
any
here.
role of FFR here?
Yeah. So, no, I mean, the point is very simple. The lumen is 2.8. So, question
Yeah, you have
comes
to
is,
do something.
in this particular case, knowing that your stent, remember the guide catheter, they should show the tracing. There is a moderate left main disease and your ostial circumflex. You need to take care of the LAD anyway.
Yeah.
So, in this particular case, otherwise,
closer.
yes, when there is a question, you want to leave it alone. Here, you don't want to leave it alone because you are going to bring your stent of the ostial circumflex up to the left main.
Right.
So, they need to take care of the LAD anyway.
You agree with
Is
that?
that clear?
I mean, yeah, of
Yeah,
course. Yeah.
No, but going back to the strategy, do we do rota versus cutting balloon here?
No, there LAD we can do.
I think
the
the
cutting
LAD
balloon.
you can
Yeah.
open it with
Cutting
a
balloon,
nice
yeah.
cutting
Yeah,
balloon.
bigger cutting balloon and then
just-
rota for the circumflex.
Okay.
So
then
if
we
everybody
just
agrees,
add
so now we get ready. So
Rotavar.
I think the OCT was helpful, and we go ahead and with our continued strategy while they are getting ready for the rotablation of the circumflex, right? That's the plan first.
Yes.
And you are going to direct wire or you over the wire system?
I'll direct wire it.
Anu, 1.5 or 175?
Aggressive, 175.
Excellent.
Yeah, I think
All
we
right.
can go 1.7 because it's a short lesion and we
large
go
vessel.
before the end.
Give me over
Bend.
the wire because there's so much calcium and after that the circumflex. So I'm going to take out the run through wire from
Yeah.
the LAD now.
Yeah.
Okay, so we are done with the job. Huh?
159 or 1.4?
Yeah, fine. Okay, whatever you have. No, 1.9. We don't want fine cross.
Okay. Now, if while we are getting these things ready, we can go back to our
Can you show this a
presentation.
dampening of the left main then?
Yeah, actually
right.
they should show that. Let's go to that. So there was a left main disease. Can they show just one tracing one time? Out now. Yeah. Hemodynamic. You have to push a little bit left main.
No, you see it. It's
Yeah,
damp.
right
Yeah,
there.
there you go.
It's damp. Yeah.
And come out. No, come out so that then only you'll see
No.
that there is a difference.
Okay.
Remember many
Okay,
times.
there.
Yeah, look at it.
Yeah.
This is the engaged. So therefore, so question is FFR is a valid question, but once you know that you may not like to avoid here, even if FFR is negative, positive, doesn't matter because you need to take care of the left main, you need to take care of the moderate LAD disease, and third is also there was a mild apical ischemia. So all those three things will prompt me that there is no need for
Field of eye.
additional physiological testing in this particular case. Okay, now we can go back to our presentation quickly. Now remember the future trial, one of the only trial which showed higher mortality with the FFR, and they halted the trial, and what they showed is the 2-year result, but more importantly explanation of the higher mortality. Now you know FFR versus angio guided PCI, and basically patient got to medical therapy, PCI or cabbage as shown here. Clearly in the FFR group, less patient got the PCI, but overall endpoint at 1 year, death, MI, revascularization and stroke were identical, so also at 2 year, that's what they showed, but more important was the individual analysis. That is the mortality was 3.7 in the FFR group and 1.5 in the control angio group, and that really led to the termination of the trial, and these are the individual endpoints. So basically only anomaly remain is the mortality. Other MI, stroke and the unplanned revascularization all were identical, actually rather favored little bit of the FFR group and so. But more importantly what we learned that why there was a higher mortality. Now basically as you can see here that the patients with a high syntax score more than 32, that actually favor the control. Why? Because there was a higher event rate in the patients with the FFR group, and now you can see here that syntax FFR group control versus FFR, that patients with a higher syntax score and more importantly the people who have high syntax score of 32 and above had a higher mortality. Look at the 4 of the 23, 17% mortality, while it was 0 because those patients didn't have the 32 and above. In the control group, patient did not have any PCI. So this to me is the explanation that complex PCI, which they led to the FFR guided PCI, really led to this major issue as you can see here in terms of mortality. So I think that's the explanation. Then CULPRIT-SHOCK, which was shown at 30 day, that the culprit vessel PCI was better than full revascularization, and now they showed the 1 year data. Basically this was a 30 day. The primary endpoint was mortality or the renal replacement therapy, but basically driven by the all cause mortality, and now at 1 year the curve remained the same way. So basically after the initial, the all cause mortality the after 30 day remain identical. So whatever happened, the CULPRIT-SHOCK, it was 30 day difference in favor of the culprit vessel PCI. That itself is mind boggling, and various individual endpoints are here which actually favor the full revascularization, because what happen is that you have a lower repeat revascularization, particularly in patient with the multi-vessel PCI. But overall I think this field still remain, but many of the guidelines has already moved forward, particularly European guideline has already made it as a class 3, the full service PCI. What do you say about that?
No, I mean, I actually am in favor. I think that if you have a I think this trial shows going after and doing so much more than what you need. You just deal with the culprit, you give the patient hemodynamic support before, during, and after, and you come out. and you actually have a better 30-day result, which is important for hospital rehospitalization and hospital quality metrics. And then the mortality is no different. And I think that the idea is to take care of it. And once they get over it, if they're doing well, if the LV recovers, if things are going well, you can deal with the other vessels. I think here, I would just be with the culprit only.
But my question is, in the regular STEMI group, and Samir will take your opinion also, we are trying to say favor full revascularization same time or the stage intervention within that hospital compared to the culprit only. So this is a little paradox.
Well, this is cardiogenic shock. These are really, really sick patients. They're very different than complete in STEMI, multi-vessel revascularization in STEMI, and the complete trial, which has completed its enrollment, and we're going to present that at ACC, is going to give us a very, very good result on seeing what we should be doing. And I just think here, there's enough data here with a large number of patients with good follow-up to show that all you need to do, instead of putting the patient into dialysis and having important issues, in fact, the culprit-only patients did better at 30 days. And those 30-day metrics are important for us in the United States and everywhere else. And you're not really improving mortality by doing multi-vessel PCI.
Samir, you want to make
yes, I think Samin will have a better idea on both the issues in the next 2 or 3 years, but there has been a clear reversal in the strategy that you are tending to favor a complete revascularization for the STEMI only lesion, whereas for cardiogenic shock, clearly doing the culprit as Holger Thiele has presented, not only with the initial but also with the 1-year follow-up, although some of the benefit was somewhat dampened, but I think as reflected in the emerging guidelines, we will be doing culprit only.
All right, so this is always, we live and learn. And then we go to the, while we are getting ready for the rota, the most important is the randomized trials of aspirin use and duration. The global leaders, the Twilight, Arrive, Ascend, Esprit, aspirin dosage, and so key is, clearly we know that you need depth.
Let's see how it works.
After DES, right? And the question all means that what does it mean? We know in the initially.
Are we ready? We're going in with the rota.
Yeah, let's do the rota first.
Yeah. Okay, so now let's stop it because this is a very hot topic.
Part to watch,
yeah. So let's go to the real stuff. Theory will come back.
Dr. Kinney works so fast, so.
Yeah, so they have over the wire, they changed it, and it was tough to even advance the over the wire system, right?
Yeah.
To the second lesion.
Pablo gave me a 2O balloon, over the wire 2O balloon.
Yeah, because what happened, the fine cross is back order, although we use some other devices.
Okay, so this is the plan. See now how to do left main. So we know there was moderate disease in the circumflex. So you leave it in the guide.
This RotaPro, this new RotaPro.
We
you leave it in the guide.
Yeah, you like it.
So everybody can see the RotaPro. Same thing, you will do your 3 steps. So you go backward, forward, and then you do your Y connector. And then when you do dyna, it's here, right? You press this one.
Yeah. Fluoro. Good.
This is a dyna button. This is a dyna button. Yeah. Then come out.
The dyna button is there, and you just press up here.
Yeah, that means you are off dyna.
Okay.
So no more pedal, no more driving. With that. So now just with the hand, same slow pecking motion. No movement, I see.
And this is, okay, here we go. Anu, this is 175?
Yes.
Okay.
Still haven't passed. That's it. There's the lesion.
20, 10, 20. Good. And 20-second runs. And the key is give a little neo. So key is that the packing. And that's a different than orbital. Orbital, you keep going forward at a 1 millimeter per second till you cross the lesion. Usually it should be in 20 seconds. But here you pack, come back, touch and come back. That's what Dr. Kinney did.
What was the speed you used?
150,000 RPM. Huh? You don't have 3.520.
That is.
So still that tight lesion, yeah. It still remains.
Tight lesion is right there now at the tip.
No.
There it is. She hasn't passed the lesion yet. I think it's right there.
Done.
No, no.
No.
That's the angle. Pull back a little bit, we'll show you. Good. Okay. Do a little cine.
I don't think so.
It jumps back.
So we clearly
Okay,
passed
good.
the lesion.
Beautiful.
Okay, ready?
Good.
Coming out.
So now, press the Dynaglide. You close
yeah.
the knob, and we are changing all the knobs hopefully soon.
And now you come
and
out.
then you have to press both brake and Dynaglide to come out.
That's the reverse care.
Yes. We can take a 3.5.
It's a
Give
little
me
bit
the
easier though.
Pay
Fielder,
attention to the
fielder,
wire.
fielder.
Roxana,
Yeah.
over the last
Give me the fielder
several
wire.
weeks,
I'll
we've
run the
had
wire.
a large group of people joining us from Brazil and
Good.
Argentina.
Yeah.
There is a group from Argentina who's particularly welcoming you and has a
Oh.
question for you.
Excellent.
The specific question for you is, besides small vessels and possibly instant restenosis, where do you think is going to be the role for the drug-coated balloons?
So, hola mis amigas de Argentina.
Bienvenidos.
Yeah.
Bienvenidos. Gracias para todo. It's
Wow.
a very, very excellent question about the drug-coated balloons. I think I believe wholeheartedly not having a drug-coated
Where's the-
balloon in the armamentarium of
Major cell?
taking care of patients is a negative, and we as interventionalists are suffering from that. So I'm hoping that we could get drug-coated balloons here in the United States. I believe that for ISR is that absolutely you don't want to keep putting layers and layers of stent, but I really do like the idea of having a drug-coated balloon for small vessels. I believe it's going to be tremendously helpful in bifurcation lesions, especially for the ostium of the bifurcation lesions where we
branch.
don't put
Yeah.
for side branch, and especially in our provisional cases where we would have a much, much better result. So I'm hoping that will come.
Yeah, and I think the ISR still remain. We actually the very limited options here, brachytherapy, and hopefully we'll get a final yes on our paper in circulation, which has about brachytherapy results at Sinai, circulation intervention. But we have very limited options. Particularly, you already have a 2 or 3 layers of stent. What you do? We need to have drug-coated balloon. Now we have used the 4 millimeter and above peripheral drug-coated balloon is available, so that we have used. So their 4.550 is the 40 or 60 millimeter, very bulky. You need 8 French guide, and we have used that in the vein graft, RCA, even some left mains. But it's a very difficult, very bulky device at present. With peripheral drug-coated balloon, you can use off-label in some large vessel,
large vessels.
large vessel DES ISR of the RCA or vein graft.
Anu, you're back with the run-through wire there.
For the
Yeah, what
circle.
is
No,
the
I run through. No, give me a 3 to 5.
Yeah, I'm sorry. What did you
Samin,
say?
another question for you.
Yeah.
And the listeners watch and
Or
hear
3 or-
every word you say.
3 or 3.
So this is a question coming from Brazil now. You mentioned that there was a small apical ischemia. Is that coming from the distal of the LAD lesion?
Well, that's an excellent point. Actually, while I was mentioning that LAD need to be taken care, so I would say it will be a reasonable in this particular case. So whatever strategy we use for the ostial LAD, you fix it, then do the FFR of the LAD, and then see
great
that whether your the distal LAD lesion is significant. Compared to the old one, we actually have an advantage of the 2008 angiogram. There was a mild lesion about 20-30%, but clearly angiographically now it's about 60-70% proximal to the prior stent. So yes, so that will be, I would say, the FFR strategy here in a modified way may be better, that you do your work, and now in the end, because he's a young guy, you want to do everything possible, and you want to do a full revascularization and use the FFR for that purpose. So we might do offline after the whole interventional of the ostial LAD and ostial proximal circumflex, and then do the FFR of the LAD just to see whether needs additional stent in that moderate, angiographically moderate lesion in the distal LAD. Very good point. Yeah, see this right now, right there.
And it's a fairly large vessel even at that area.
But see, they are actually little calcium. It's before the stent, and we actually, as I said, that we have it in the different area. We have the old angiogram to review. So now, while they are doing it, let them prepare.
But then you see, go back. The apical LAD has severe diffuse disease, so it could be from that also.
Good. Okay. So now we go back to our slide presentation for about 5-7 minutes, and key, the topic is the big issue. The big issue is we have been thinking that we need to do the DAP. We cut down the duration of the PTY12 inhibitor to decrease the bleeding because stents are getting good and good. So recommendation has been 6 months in stable, 12 months in unstable patients, DES and or acute coronary syndrome, and we always have just reduced the DAP duration. PTY12, whether 3 months or 30 months as in the DAP trial. But we have not thought about the another culprit, and other culprit could be the aspirin. Why we take aspirin for granted? So maybe the aspirin is the problem. So therefore, now 2 trials, global leaders which has been presented last week in European Society, where they give ticagrelor 24 months and aspirin for 1 month. And the second major trial which has completed, and ask Roxana Maran is the PI of the Twilight, where the aspirin for 3 months and ticagrelor for 15 months. So the 3 months both, and then 12 months randomized. So 15 months kind of. So we'll learn. So basically there is a rationale behind ticagrelor monotherapy. That is, it is a potent and consistent antiplatelet drug, maybe a better foundation as a monotherapy for long-term antiplatelet therapy compared to aspirin all-risk patient, and avoid the higher risk of bleeding potentially associated with adding aspirin, even low dose to ticagrelor. The most important is that maintain the clinical benefit of potent antiplatelet inhibition after PCI beyond the initial period of high stent thrombosis of 30 to 90 days, 30 days in global leaders and 90 days in the complex PCI of the Twilight. So basically what we still giving importance to aspirin for first 30 days, because stent thrombosis could happen, maybe you need both of them. But before, maybe in the future, if these both trials shows that 30 and 90 days are good, so maybe then we can skip even 30 days. But right now, that's where we are, that give it at least for 30 days or 90 days, and then give a mono therapy of the ticagrelor, knowing very strong agent. So this is published in Lancet, presented the global leaders, presented in European Society, very complex design, large number of patients with the primary endpoint of the 2 years all cause death and non-fatal MI, and of course the trial design and all have been shown here. And this is the overall the scheme. Scheme basically experimental strategy was give in both patients ACS or stable CAD, give aspirin less than 100 milligram for 1 month, and you start the ticagrelor from the beginning and continue 90 days, 90 milligram twice a day for 2 years. So that's the experimental. Now it was compared against the control or reference. Reference we know in ACS, you give aspirin for 24 months and you give ticagrelor for 90 milligram twice a day, that based on various trials. And stable CAD, aspirin for 24 months and clopidogrel for 1 year 75 milligram per day. So it was a very complex design paper, strategy, but done very well in 16,000+ patients. And of course, all these got the biometric DES and bivalirudin as their anti-thrombotic therapy. And basically very good compliance, over 90+% compliance of the assigned strategy as shown here. But what did we find? All cause death is on the left side and the bleeding is on the right side. So at least what we learned, that the all cause death was 3.17 in the reference arm, and in the experimental arm basically was 2.81. So it did go down, but non-significant. P value was 0.182. Also importantly, we learned that by discontinuing aspirin, there was no difference in bleeding, as you can see here. So you can see on the right side, there was no difference in bleeding. These are the individual endpoints of the death and MI, which is the primary endpoint. You can see 4.4 going down to 3.8, and then you have the death, P value of 0.10, MI 0.14, identical stroke rate, identical bark bleeding, and the target vessel revascularization. So and more importantly, stent thrombosis. What is the biggest concern taking away one antiplatelet therapy is the stent thrombosis, and we found no signal, but at least you could say in the positive way that taking away aspirin did not harm the patients. So that's the key. So now these are the individual other points. So basically they concluded that ticagrelor in combination with aspirin for 1 month followed by ticagrelor alone for 23 months was not superior to 12 months of standard dual antiplatelet therapy followed by 12 months of aspirin alone in prevention of all-cause mortality or new Q-wave MI 2 years after PCI. So, basically it showed that it was non-inferior, but I take it in a different way, that skipping aspirin did not harm the patient, but of course, giving a ticagrelor itself has its cost unless you show the benefit. There was a little signal, maybe if you are 30,000 patient could be positive, but did not show so. That is where we are. So, then we now it really in the heel of the twilight, which is a very important trial which is published in AHJ in terms of the trial design, and Roxana Mehran and Usman Babar. Roxana is the national PI and I am the local PI for the twilight, and I will ask now Roxana to talk about it, that what is the concept behind the twilight, and which now verily, you know, everybody is very eagerly waited that this concept has to make sense of the monotherapy. Roxana?
So thank you, Dr. Sharma, and all of you and all of the listeners for, I mean, I think the case is very, very interesting. And Dr. Kinney, thank you for having me here and to allow us to give a little bit of a platform for the Twilight study, which I think is going to be the long-awaited patients. And I think it's very important trial, especially in the current milieu where we are. Global leaders, I loved your presentation, but I think it is important to note that that pragmatic design of 16,000 patients, the patients did not stay actually on the experimental treatment. There was about a 23% attrition in that group versus completely following the situation. To me, that's a negative study that actually is very positive for monotherapy. There was, as you said, not a signal of harm. And our idea was, how do we keep patients? Can we take the patients who are going home on ticagrelor for a complex disease, whether it's acute coronary syndrome or stable syndrome of complex PCI, multiple stents, enriched population, high level of diabetic patients? If they're going home on ticagrelor, can we put them on for 3 months, aspirin ticagrelor? If they did extremely well, can we continue this for another 9 months or 12 months later? 12 months later for a 15-month period of observation. And in that 12 months, the patients will be on ticagrelor plus placebo versus ticagrelor plus aspirin. This is a double-blind, placebo-controlled study. We have already enrolled 9,000 patients. We completed the enrollment. It's important to note the inclusion criteria. As I said, these patients had to meet a couple of criteria for a complexity with multivessel disease, or if they were old, or if there was a long lesion, multiple stents, more diabetes, etc. We excluded patients with STEMI or those patients who presented with who couldn't be put on a ticagrelor therapy, and you as a clinician wanted to put the patient on ticagrelor. We enrolled the first patient in July of 2015. Last patient was enrolled as of December 31, as we promised, the last day of 2017, 9,006 patients enrolled, and we randomized 7,119 patients as of April 12th of this year, 2018. So we actually enrolled 79% of the patients who were, we randomized 79% of the patients who were enrolled. All those patients, 99% of them, have stayed on their regimen on the study. 11 countries, 187 sites, 98% follow-up. Nobody is withdrawing because already, if they can't tolerate ticagrelor, they're coming out of the study. The study period starts from randomization. We will complete the trial next July and have the final presentations as of now, either at TCT or AHA. We'll see where we're going to go. Yeah. So I think it's really important. I'm really proud to be the global PI and to have Dr. Sharma as one of the executive committee members, not just a site PI here, but you're on the executive committee. Dr. Kinney has been an incredible contributor and supporter of this study, and of course all of it would never be possible without Dr. Usman Babar, who's leading the clinical coordinating center, keeping everything firewalled from me as the PI.
And the 20%, just want to update, that 20% return to the randomization less was because in 3 months patient developed some events
or shortness of breath or whatever.
So basically really that was their prediction, was that it was little off, slightly
less than what we had
less
hoped.
than, but still but question is, you'll get answer in 7,200 patients. The question you're looking for.
We will have answers in 7,119 patients. We're fully powered to show. And our primary endpoint, remember, is that we will reduce bleeding without increasing ischemic events. What do you think is going to happen?
No, I mean, clearly that the bleeding will decrease. But now let's say both items, bleeding as well as ischemic events, are identical. The two scenarios. One, your hypothesis, which I wish should be correct, and I would say will be correct. If you ask my prediction, that yes, ticagrelor monotherapy after 3 months of aspirin will be a winner. The question then comes is that what if a small chance that they both are identical? What will be the take home message will be then?
If we don't reduce bleeding by taking away aspirin, we've done something wrong. It would be either our sites didn't report it or what. I mean, there's no question that aspirin in combination, or our patients took aspirin besides the, I mean, they took it. I don't know. I could imagine that would never happen. People are staying in their regimen. Aspirin causes GI bleeds. Look at the studies that we just saw. Ascend, yesterday, Esprit in patients, elderly patients, all aspirin is doing is increasing bleeding. In diabetic patients in Ascend, all aspirin is doing is increasing bleeding, not reducing cardiovascular events for primary prevention or in high-risk patients. So I think we should be able to show something.
I agree with all the comments you've made, and truly a transformational trial. Congratulations. But what about the subset of patient post MI and those with the high risk factors for the longer duration? I'm talking about even up to 3 years. What happens to them?
What will be the, ask again, sorry.
What do you think happens to the subset of patients who are truly high risk post MI? You think monotherapy there for a much longer duration should also suffice?
Look, I mean, we're not going to be showing those data, but I think if this, especially for your high bleeding risk patients, what's important to note that you could go safely on ticagrelor monotherapy if this double-blind placebo-controlled data is positive. I mean, the fact is that we're taking complex patients, and it's a double-blinded study, so there's no bias whatsoever.
Congratulations again, Roxana, and as promised, 9:20 we have.
Yeah, that's great. Thank you.
Gotten you through it.
Thank you so much.
Samin, in the meantime, as I had mentioned in my introduction, we welcome Dr. Nick Cruz and a group of fellows and junior operators from St. Luke's Medical Center. They have a 12-hour difference in the Philippines, and they are watching the case.
Okay.
They also mentioned that they use the drug-coated balloons very often for in-stent restenosis, occasionally for side branch and small vessels, guided with imaging. Exactly the right strategy to have, Nick, as we discussed, and thank you all and welcome to the group who's joining us.
Okay, Anu, tell us what we are doing now.
So we have a 3024 to the circumflex.
You want to show what you did?
So this is what happened is when we are doing the cutting balloon, I have seen it a few times. So this is the cutting.
Oh, sorry.
Cutting balloon for the proximal LAD.
Yeah, that was okay, but then when we went to the prox LAD, see here?
Yeah.
Exactly where that calcific
plaque was.
Nodule was, did not expand. So I think we have done this teaching in the past. Bring the cutting balloon into the guide, go back in, essentially your blades will be rotated. So I did it multiple times, and then finally we had that result. It did expand.
Yeah, very good.
Yeah. So now this is the final we have.
That was the 3.5?
That's a 3.5 in the LAD.
Yeah.
So we had a 3.0 in the circ and 3.5 in the LAD. So now this is where we are. We could go either way. I think since the left main is short, V stenting is not an option, though it is 0.11.
Anu, just take a look at the angiogram of the circumflex. You think that is some residual calcification, or is it a little
no, you see that it's just a circ tortuosity.
Haziness, no haziness there beyond before the tortuosity.
That angle.
No, no, that angle is not residual calcium.
Okay.
I think calcium plus the tortuosity of the circ giving that haziness
Okay.
look, and wire bias by the rota.
Yeah. Okay.
Yeah. So now we have a 3024 in the circ, which I think will be okay. It's just okay. If our plan was to do mini crush, so we have a 3520 in the LAD, and let's see how we will do this mini crush. Like I said, to do V stent, you need a left main, large left main, so that the stent, which is a 1 to 2 millimeter, has to be sticking out in the left main. Here we cannot do that. So you have only option of either we do a mini crush, DK crush, or culotte. So we of course will go for mini crush.
All right. So
Anu, also three apps already you have, the bifurcate, the octade, and the transeptate.
Yeah. So today, no, I was going to just mention to you, when we did OCT, if there was any question that we could have done the, you could see the octade. You have octade, which is an app, plus we have a website. So you can go to octade.com. If you do that, you can see it, a website, which is a nice website if you are not able to download it. Otherwise, you can download it from Google Play or from the Apple Store.
So it is also in recognition of your app generating ability that I am seeing this amazing title of your talk at TCT, Rise of the Planet Apps.
Yeah.
All right.
way
to go.
Yeah.
They have a new category. They are saying that fascinating lectures, where they are talking about.
It's a very pertinent topic. Samin, let me take you more into some other. Let's try to extend. I know it will be a while before twilight data comes to us, but it seems very clear that you need to block multiple pathways of platelet inhibition in the very early stage, and then focus on the P2Y.
Yeah. So I think once you do 1 month, I think that's a good enough.
Good. Nice. Good.
12.
So this is a mini crush, same that were down. We did the circ, come down.
Go up again.
Go up again. So so you could use 2 apps here already. You can use a bifurcate app to see the steps, and OCT app to check how to do OCT.
Excellent.
And yeah, you were saying that transeptal, how to do transeptal procedure, that app will be released Friday 5 p.m. because we are presenting the same, a poster on the transeptate app
at the TCT.
At the TCT, and will be, that app will be released. It's ready for release. Approved, already approved by App Store.
Samin, here is another very stunning observation I made at the AICT meeting in Hong Kong recently, that in several of the Southeast Asian countries, the use of OCT is almost as high as in 10% of the cases.
Yeah.
Wait. Yeah, nice. Okay, go up.
So I think
OCT
that all
use is very high outside America.
No, but I think it all started with the bioabsorbable, and the machines are still there in the cath lab. They had to use it. Believe me, the same thing in my hospital in ESCC.
Right.
So, but we learned that while it looks very good, but we still need to show the data clear cut that OCT helps.
Means it has to make up to the guidelines.
Yeah, that's where we are still. So while we are doing it, I'm not a big proponent yet till any of the trial, because all the trials so far has been plus minus, some positive, many of them are negative, but Illumin is the 4th trial, is the one which will answer this question in a large randomized fashion.
And there is a learning curve to do this OCT, plus you need to
use it absolutely safely.
Safely, that's one, and also understanding interpretation of the images.
Good.
And that is where the OCT app will help you.
Exactly right. A lot of examples in that.
Lot of example quiz questions, and we have a section called Ask the Expert, where people have been sending images to us.
And look at the no dampening now. They should be able to show that. Good.
Nice.
Beautiful.
You're happy with the ostium and the very proximal portion of the circ, or
Yeah.
that of course
So,
requires?
Yeah,
No,
yeah,
no.
same. I think a millimeter not covered. We were just talking once we do the kiss.
Yeah,
That should cover it.
yeah,
that
yeah,
will cover
exactly.
And same thing. What we always teach now. The wire is in the guide. The fielder wire that was in the circ is in the guide. Will go back there, and in the left main is the same. You can go with the NC balloon to recross now.
Yeah.
We will need a new NC balloon.
Yeah, which we are 3.5 ready.
Yeah. Yeah.
Yeah,
Anand,
good.
there were
Yeah,
a few
go.
follow-up questions and comments regarding the rotablator entrapment. And there was a theme there. It seemed to suggest that this may be a little more prevalent issue with the new system.
Yes.
Yeah. So we are definitely working with the engineers. They came and we showed the cases. We actually had 2 entrapped bursts so far, and the both were able to successfully remove by our technique. But definitely this has been the issue, and whether it's happening a
What
little more.
length you gave me? It's not
This
going
is
to go.
3.5. Quite new.
So, Samir,
No,
if you
Absolutely will not go to the circ.
if you were
Give
to
us
There is a
3
3
or
or 12.
compliant.
3
Yeah,
or
compliant.
12. You
Yeah.
can give a 3 or 12 compliant balloon.
Compliant, yeah.
we discussed it just because
You
of
wanted
the
a 3 or
interest in the
3.5 to the
people
circ?
following up.
Yeah, could have been.
No, it's not
Yeah.
going to go. You saw that.
Yeah, I'm sorry, say it again.
I know that when this case occurred, we had discussed and spoken at length,
Yeah.
but because so many people have asked the same questions, how would you summarize the management of burr entrapment?
Okay. So I think then what will be the best way would be that I'll make the slide in our next presentation.
Yes.
So I think that probably will be the best way.
No, what happens is actually I am also making the algorithm so
And
that
we are making that algorithm
people
and we are
will
publishing
understand.
that, sending it for publication with these cases. And so.
see the difference 12 versus 20.
No, it was not 20, yeah.
No, it was
3.5.
20. They gave a 3.520 balloon.
Yeah.
It was 20.
Okay.
We were just discussing because if you want a non-compliant balloon to go
Put a
through
3.5. bring
this
it
kind
to
of
the LED.
bifurcation stented lesion, you need to take a 12 millimeter balloon.
No, we have 3.5 there.
20.
A shorter one just
Yeah.
to
Yeah,
the
to make
winging
sure.
and everything.
But a NC balloon will go through. But if you are doing LED diagonal, NC balloon may not go through. So we always taught you go with the compliant balloon first and then go second time go with the NC balloon.
But I think in the left main is okay because left main many times
that I'm
we go.
saying the left
Yeah.
main we will
Yeah.
go, but 20 millimeter balloon will
Yeah.
not make a turn into
Like
the circle.
12 or 15 should have been the one.
I mean go 12, keep 12. So now we have a 3, 5, 20 in the LED. So this is for the kiss, final kiss.
Now let's dilate there.
Okay.
Yeah.
So some of the stent is, you were distal, okay, down.
No. It's a compliant 12 millimeter.
It's compliant or non-compliant?
This is compliant.
Sameen, a question from Brazil for you.
Yes.
What would be the
No, go to the
dual
LED.
antiplatelet strategy with the new data and if there is a re-emergence of the BVS?
This guy had his PRU checked last time.
Yeah. So in this, this
80.
patient was already on ticagrelor
80.
because he was a non-STEMI.
Down.
That was the right approach for him. And the question will come that would you be able to stop? But I think any patient with acute coronary syndrome that
Go, kiss.
still we have the data. I still will be concerned. The stable patients, I have no objection. Go ahead. To use a single antiplatelet therapy.
Okay.
No,
You
the
go more?
question is,
Go
Sameen,
down. You
if there
said-
is a re-emergence of the BVS platform.
Yeah. So no, that will be the same. That
Okay, down.
that
12
no, there I can tell you the BVS. You need all the dual antiplatelet therapy for at least
At
3
least 12
years.
months.
At
2
least
years.
3 years.
Okay.
36 months. Yeah.
But we will revisit that topic should the BVS re-emerge.
Yeah. That's right.
Good, coming out, right?
Take a picture. Okay, that's fine. Okay. So, we are ready to take a picture and then complete. Go to little AP.
Ready? Good.
And clearly the damping has improved
Yeah,
there.
yep.
Don't see it.
Good.
Good? Okay.
Yeah.
I just wanted to say the distal edge ulcer. Ready? Looking good.
You happy with the very proximal portion of the LAD?
The question is, should we dilate with the 4O?
Right.
No, I think this is where the calcium spicule was and never expanded, and then you see that.
Yeah.
I think it's the calcium behind previous calcium, and this will never be. I don't think we can go crazy there.
And we know also, you know, I just say that you get, you know, DBC, don't be crazy. You get too crazy, you perforate.
Yeah. So let's. I think everything
it
looking
just happened yesterday in our lab.
Okay, everything looking good.
Yeah, the stent is nicely expanded. That's okay. If not expanded, little narrowing, that's a the lumen. If you feel that lumen is really good, 3+ millimeter, then I think it's reasonable to just stop it. And then this is the only question we are going to do FFR offline to see that whether patient needs anything for the distal LAD.
Right.
You want to do OCT now?
You want to do OCT? Take a picture.
Go.
I think it looks very good.
Very good.
Good.
Yeah. Even LAD flow has improved since then. Although we did a epicranial or no?
Where?
Just now.
No.
No.
You want
So
epicranial?
even the proximal looks much better. Okay. So while we are just finishing, I think we complete our today's presentation, which went a little more than our usual, but that happens time to time. And if we can just go back to the, now what I am going to show very rapidly is the aspirin, that how the few trials, the 3A, arrive aspirin and ascend in various risk group have shown overall negative impact of aspirin. So one of them was the ARRIVE trial, the patients who have moderate risk of cardiovascular disease, not, these are already primary prevention trials, not secondary, primary aspirin versus no aspirin, and basically showed in large number of patients that there was no benefit, rather you cause more GI bleed by using aspirin. Primary outcome of death, stroke and MI no different, and rather you cause more bleeding. And then second was the primary prevention patient with diabetes, ASCENT trial, where there is no clear cut CAD in those patients. Again, what did they find? By giving aspirin, you have an identical MACE rate, as you can see, of multi-year follow-up, 7, 8, 9 years, but aspirin caused more bleeding. So clearly, again, second message, diabetic patient with high risk, and so, and of course they took it individual event rate based on the Framingham, and again no different. Then ASCENT trial, basically that's what concluded was that since the event in the diabetic patients, there was no evidence of cardiovascular disease, but it caused more bleeding. And then the other question was that whether in terms of the weight base. So we also learned that aspirin is a weight base. So latest data just came that patients who are less than 70 years of age, 70 kilo of weight, your 100 milligram is enough, but more than 70 kilo of weight, 100 milligram may not be enough. That low dose which we call maybe does not give that benefit, and so. So then basically the last one are 3 trials presented yesterday, which are the various groups of the aspirin, which is aspirin on cardiovascular event and bleeding in the elderly. Elderly they defined as more than 70 or 65 patients who are Hispanic and blacks. So all cause mortality, the disability free survival, and of course the cardiovascular event and bleeding, and basically showed all these trials. These are the large number of patients, as you can see here, 15,000+ patients, overall showed that no difference in cardiovascular outcome, rather you have a higher bleeding rate. There is also a signal, there is signal of higher cancer rate. So therefore this whole thing, I got multiple phone calls yesterday, is just to the total in the public frenzy that should you be taking aspirin. And I think based on the data now in the large number of patients, we can safely say that probably you do not need to take aspirin, which are not shown any benefit of survival, particularly in the elderly patients or patients who are at high risk, moderate CAD risk, not necessarily as a secondary prevention. So, just to complete, the randomized trials of radial versus femoral access during PCI again showed the superiority of the transradial access over femoral approach. Bivalirudin was not superior to unfractionated heparin in reducing MACE, and the drug coated balloon they have a promising result in the small vessels, and the long term follow up of the CULPRIT-SHOCK and the future trials showed consistent results as of the short term follow up, with higher mortality in the FFR guided PCI in the future trial mediated largely by PCI in the high syntax risk score patient, and that is where you have mortality of almost 17%. Then the shortening aspirin duration post DES with ticagrelor monotherapy is promising and is not associated with higher MACE rate. Although this was not statistically better, but there was no higher MACE rate. The twilight trial will be the landmark trial to settle this issue, and also the randomized control trial of aspirin use over placebo in various patient subset have showed no overall benefit with potential for higher bleeding and maybe cancer, and routine use should be discouraged as a primary prevention. So, we have 3 questions. Following is the likely explanation for the higher mortality in the FFR guided group versus angio guided group in the future trial, that FFR assessment caused complication, FFR use caused higher overall MACE, FFR use caused higher MI, FFR guided PCI in high syntax score caused higher mortality, and FFR caused higher strokes. Second, following are the 1-year results of the matrix trial except lower cardiovascular mortality in radial versus femoral, similar MI rates in radial versus femoral, lower bleeding rates in radial versus femoral, then higher stroke rates in radial versus femoral access, and lastly the overall NACE is lower in radial versus femoral access. The third question, following are the true statement regarding the results of global leaders trial except that experimental arm was not superior to control arm, experimental arm had higher stent thrombosis compared to control arm, experimental arm had similar bleeding to control arm, experimental arm had similar stroke rate to control arm, and experimental arm follow up was less than 80% compared to control arm. So, basically these are all the questions which we had based on the presentation, but in a nutshell the aspirin is just going out of favor.
I think you handled this very maturely, Samin. These were some of the trickiest areas emerging out of the press, and you've covered all the 3 recent NEJM trials extremely relevant fashion, and hopefully with some of the new trials the data will become clearer. Yes. I also want to thank Dr. Roxana Mehran for joining us today and explaining the twilight trial further. Anu, great case. Final.
Yeah, we have done the OCT at post. So
they have done the post is OCT also.
Tell us what you find there.
So if they are going to show it there, right?
It's shown. It is being shown there.
We see it here. Yes.
Yeah.
Okay. So this is where we are. This is the distal edge. You can see that. You see here. This is that white dot which you are following, and on the right side it is showing. See, nicely opposed stent of the LAD. Now we are coming up to, this is where the concern was, right here where the concern was.
Yeah.
See how opposed it is.
What you wanted to leave alone.
Yeah. This is the way it was before, and now it looks the same. You see that? It's well opposed. So whatever it is that we are seeing,
it's a very large lumen area too.
Yeah, and your calcium is probably somewhere outside that you don't see. You are getting a, you see that your cross sectional area coming almost to
about
6.2.
6.24.
Yeah, so it's a good one. So you're now coming back proximal a little bit here. Yeah. This is the ostium, 6.9.
Right,
yeah.
And in between it fell to around 5.8 or
5
something. Looks,
yeah.
Sounds, so you are happy with the result?
Yeah.
Excellent. Anu, any final take home message?
No, Mav, I think the final take home message is the how we planned, you know, that how imaging did help us, whether we could, remember we have shown, I am not sure if they have shown cases when you have ISR which is really old, especially first generation stent, or even if it is a second generation stent, ISR we are talking more than 5 years, that we have from based on our personal experience is that we would consider atherectomy, especially rotational atherectomy. So, here the decision was made based on the imaging, despite we saw the calcium nodule, that cutting balloon should suffice, but we showed that even cutting balloon did not expand, but we had to do the technique of deflate the cutting balloon, bring it back to the guide, reorient it, and that way it gave us a good atherectomy result. And after that, how we place the stent, and the stent technique was same, that we showed mini crush technique, but here V stent was not an option, since it was a short left main. Either decay crush or culotte could have been done in this particular case.
Excellent teaching tips, Anu, great case. I want to end by thanking our viewers in the Philippines, Argentina and Brazil specifically today. Thank you for your questions, keep them coming, it will only improve the transmission quality and make it very useful for others. We are going to conclude here and see you during the next session on October the 16th.